Bismillahir Rahmanir Rahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. I am Dr. Mudassir Shahbaz, Associate Professor, Anatomy, Sahara Medical College, Narawal. And these lectures are recorded for the first year MBBS, and they have, as we know that we have completed our upper limb, and now we are learning or talking about the anatomy of the gross anatomy of the lower limb. And during our discussion, we have discussed about different things of the lower limb. Now today we are going to talk about the anatomy of the hip joint. Before we start our discussion on the anatomy of the hip joint, I would like to briefly recall you that I have, as we have discussed in the classrooms, that whenever we are going to learn about the anatomy of any joint, there are different questions that automatically those questions comes into our mind, and we want to know their answers. The very first question, what joint we are going to discuss, and that joint is the hip joint. Now, where is that joint? This joint is in our body. In our body, where this joint is present, so we can feel the. If we put our hand on the lateral side of our upper lateral side, we can feel the bone, that is the upper end of the femur bone, gluteus carotid. So here is the joint located in our body. So now the next answers that what is this, among which bones this joint is present, what type of the joint is, what are the ligaments that support the joint, how this joint is formed, and how the capsule is attached. We will seek the answers of these questions during our discussion. So when we see that there is a hip joint, then we come to know that it is a synovial joint, and it is a ball and socket joint. So here we can recall that we have discussed a joint in the upper limb which was a ball and socket and synovial joint, that is the shoulder joint. And when we were learning about the shoulder joint, we have found that that shoulder joint is multi-axial, that we can move our shoulder joint in all directions. We can multi-axial means we can produce movements such as flexion, extension, abduction, adduction in this joint, and also the circumduction, that is the combination of all these movements. So it means that there is degree of freedom of movement in these joints, which are ball and socket joints. That's why they are called as multi-axial joint. So these kinds of joints, they can be moved in three planes, means around the anteroposterior, around the transverse direction. It can be moved in three planes, and but there is always some limitations in the movements. And in this joint, hip joint, as we have found in the shoulder joint, that when we produce the adduction, it is limited by the chest wall, and abduction is quite free. So certain movements, they are limited. So in case of the hip joint, then when you are going to extend the hip joint or you are going to medially rotate, there are limitations of the movement of these type of movement. and the flexion is the limited by the anterior abdominal wall. That is, we can say that this is the semi-flexion. So it's when we were discussing about the shoulder joint, there we have found that it is quite unstable joint. It was shoulder joint quite unstable because of degree of freedom of movement. You have to sacrifice the stability of the joint. But in case of hip joint, this is not so. This joint cannot be let unstable by the nature. Why? Because you are running, you are walking, you are moving on this joint and bearing whole of the weight of the trunk and upper part of the body on this joint. So it cannot be let stable. So it is a quite stable joint in the body. Although there is a multi-axial freedom of movement, but it is a stable joint. How is it stable? That we will see when we will see its articulation, articular bones, how they are arranged. But that's the thing as compared to the shoulder joint, which was unstable because of freedom of movement. This joint is not unstable, but it is one of the stable joints. And articular surfaces of hip are reciprocally curved, means if one surface will be concave, other surface would have to be convex. So that a ball could fit into the socket. And because they have to bear the weight and great pressure, they have to sustain a great pressure of the body weight. So here we can see a diagram that is showing the articular surface. So here see one articular surface over the hip bone. You have studied the hip bone, and there is a part of the hip bone where all three parts of the hip bone, that is the ilium, pubic and ischium, they come together at the place which is called as acetabulum. So here the acetabulum is shown, but this acetabulum is concave in nature, that will into which the convex head of femur will join it here. But this cavity, as in the shoulder joint, we have seen that the glenoid cavity is not so deepened, that is shallow. But here, to make it deepen, there is another thing placed here, that is the labrum, acetabular labrum, placed so that the cavity is deepened to fit the head of the femur. And here we see it is a more circular, semicircular head of the femur, more than the head of the humerus. The femur head is more larger than that. And here, for the stability purpose, a ligament is attached that is named as foveal ligament, and this ligament, head of femur, is attaching head of femur to the acetabular notch here. And here the notch is completed by a ligament, transverse acetabular ligament, between the two margins of the free margins of the acetabulum, and below this ligament will be the acetabular notch, acetabular foramina, that will convert the notch into a foramina. So acetabular notch is converted into a foramina by the transverse acetabular ligament. So we see that the acetabulum is actually, what acetabulum is, Y-shaped epiphyseal cartilage by the ilium, ischium and pubis. They join together in a Y-shaped manner. Here we can appreciate that. And most of the part is played by the ilium and ischium, and lesser part by the pubic part of the, and it remains as a cartilage up to the 12 years of age, and they fuses together and ossifies by the age of 16 to 17 years of the age. This is the age, see how the nature has provided us with this, that this is the age when you are playing, running, and doing all the things. At this age, it becomes ossified and more stable. The notch is inferior, and this non-articular surface, non-articular fossa, this related medially to the obturator internus. So here some part will be showing that the medially there should be the obturator fossa for the obturator internus muscle, and the pad of fat and proprioceptive fibers will be here in the acetabulum. So the acetabulum is a semilunar surface covered with the hyaline cartilage deepened by the acetabular labrum and wedge-shaped fibrocartilage. A wedge-shaped fibrocartilage, that is the acetabular labrum. It deepens the cavity, the acetabulum, and it's a semilunar half-moon articular surface. Head of femur is a two-thirds of the hemisphere, two-thirds of the sphere. In above, if we recall the shoulder joint, the head of humerus was one-third, but here the femur head is two-thirds of the sphere. And there is a pit over the surface that we have seen before. Here we can appreciate that the pit for the ligament, ligamentum teres, or ligament of head of femur, and is also covered by the hyaline cartilage, articular cartilage, thicker posteriorly, superiorly, because of the movement. Epiphyseal line of the head of the femur is intracapsular, as the epiphyseal lining is intra-articular of the head of femur. You have studied the femur bone, and then you can very well recall it as. So we have learned about what we have learned up till now. From this diagram, we will recall it that the hip joint is a synovial joint of ball and socket type. It is have quite freedom of movement, multi-axial, three-plane movement. One of the articular surface is the acetabulum, which is cartilaginous up to 12 years of age by the three bones, ilium, ischium, and pubic part, that ossifies up at the age of 16 to 17 years. This is deepened by the acetabular labrum, and inferiorly there is a gap that is named as acetabular notch, which is covered by the transverse ligament and convert it into the acetabular foramina for the passage of neurovascular to the head of femur. And here the head of femur, which is covered by the hyaline cartilage, which is thick posteriorly, and here is attached the ligamentum of head of ligament of the head of. Here is the ligament capitate or round ligament of the head of the femur attached here to stabilize the joint. See, it's a two-thirds of the circle, head of the femur, and the epiphyseal line here will be included within the capsule of the hip joint, so that we can recall it. One thing I want to mention here also that is that whenever you learn about the things, there is also a method which is named as self-assessment. If you have learned certain things about anything in the anatomy, then to self-assess yourself, as we have reached up to this slide and this diagram. So for purpose of self-assessment, try to recall all the properties that initially you have learned about the hip joint and try to apply it by seeing this diagram. And this diagram, when you apply your knowledge here and recall the things what you have learned, how much is the sphere of the head of femur, what is this, how it is deepened, what is ligament, and what purpose of this stability, and then you can recall it and you can self assess that have you understood all the things by recalling over a fixed diagram. That you can open this diagram anywhere in your atlas, in your book, and try to recall all the things that you have learned up till now. This is a method of self assessment, self learning, and it's a very good method if you are able to recall all the things that you have learned up till now over this diagram. Then I think so that inshallah that will be remembered to you for a long time. And whenever at other time this diagram will come in front of your eyes, automatically the things which you have learned, it will be recalled by you immediately by seeing the diagram. So it's a very good method of self-learning and self-assessment. Both things can be fulfilled here. So next thing is the ligaments. If you come, we have learned about the articular surfaces. Now is the ligaments, and very first ligaments of the synovial, any synovial joint, is the capsule of that joint. So capsule of hip joint, here we see it's proximally attached to the marginum acetabular fossa, obviously, and base of the labrum, distally anterior to the intertrochanteric line. Between the two greater and lesser trochanteric, there is a line which is called as intertrochanteric line. So anterior to it, it will lie anterior to the joint, inferiorly from the close to the lesser trochanteric. So inferiorly it will be more close to the lesser trunk. Here we can appreciate the attachment of capsule of the hip joint. It's very important to learn about the capsule, how it is attached. So we have seen here the attachment of the capsule. So posteriorly there is a free border finger's breadth from the intertrochanteric due to insertion of obturator internus, because obturator internus will be inserted here. So there is a finger's breadth from the intertrochanteric crest. There is a free border into the trochanteric fossa and greater trochanteric root of the. So the muscle is attached to the intertrochanteric fossa. That's why there has to be a gap, free border posteriorly, because of the muscle which is obturator externus muscle, for the attachment of that muscle. So again we see the capsule is strongest superiorly, anteromedially deep fibers reflected head of rectus femoris. So anteromedially there will be deep fibers reflected head of femur, and iliopsoas will be also anterior, and lateral deep fibers of gluteus maximus will be there. So we can understand this, that because we know we have seen the origin and insertion of the iliopsoas, so we can imagine that the reflected head of the rectus femoris has to pass anterior to it, and also the iliopsoas, which is passes anterior to the joint, to be inserted into the lesser trochanteric. Also we have seen the attachment, distal attachment of the gluteus minimus. So other ligaments, then the capsule joint, are the acetabular ligament, transverse ligament, ligament of head, iliofemoral, pubofemoral, ischiofemoral, and zona orbicularis. The first three ligaments we have seen already. Acetabular labrum we have seen, how it is. We can go back to this diagram, and these ligament, first three ligaments, that is acetabulum, ligament of head of femur, and, and here is the transverse ligament. These three ligaments we have seen already, which are the ligaments of the obviously capsule also is included within this. So these three ligaments which supports the purpose of these ligaments is to stable the joint, and first of acetabulum to deepen the cavity, and this is head of ligament of head of femur ligament is the purpose of this to retain the head of femur into the cavity, and this is because there is a gap to fill this gap and convert the acetabular notch into the cavity foramina by the transverse ligament. The other ligament are the three ligaments are important: iliofemoral, pubofemoral, ischiofemoral, and zona orbicular. So we will see these ligaments one by one. So that the transverse ligament, part of the labrum, ligamented triangular at its base attached to the transverse ligament and apex to the pit of the head of femur. Same the ligamentum teres we have already seen. Here is the ligamentum teres, and this foramina is blood supply of the epiphysis from the obturator artery enters through its own supply is the flake of bone in elderly. Iliofemoral ligament. First, thickening of the capsule, obviously lower of anterior surface of here is the iliofemoral ligament. Anterior inferior iliac spine will comes down, and then the acetabulum adjoining distally upper and lower part of the intertrochanteric line. Here is iliofemoral ligament that is attached it, and its actual is the thickening of the capsule. So we can appreciate this. This will be anteriorly from anterior inferior iliac spine and adjoining acetabulum to the intertrochanteric line, iliofemoral. One of the strongest ligaments, tightens in extension. Obviously, if you imagine extend your hip joint, you can feel that is the iliofemoral ligament should be taut in the extension. Maintain the erect position, and on the anterior it creates a facet on the anterior aspect of the femur neck and prevents hyperextension and is fulcrum reducing the hip. So this ligament iliofemoral is tightened during extension and will prevent hyperextension, and it's a strong ligament, quite a strong ligament. Pubofemoral ligament, from the pubic bone to the pubofemoral ligament. Spiroramus of the hip bone, pubic part of hip bone, intertrochanteric and an upturned part, intertrochanteric line and upturned part. Relatively weak, prevents abduction. So if you look at this direction of the fibers, if you want to abduct it, it will be tight. Iliofemoral ligament. And there is a bursa between this part and the iliofemoral part. Here should be the bursa. Then is the ischiofemoral ligament. It can be seen posteriorly more easily. So here we can see from the posterior view here the ischial bone. So here is the ischiofemoral ligament, and it's a weak ligament, circular fibers called zona. and the circular fibers, they will be called as zona orbicularis. So because the center of gravity is in front of the head, synovial under obturator externus. So from here, the obturator externus muscle will come to be inserted into the intertrochanteric fossa. So there will be bursa between the obturator externus muscle. It's also a weak joint. So the most strongest is the lliofemoral, then is the pubifemoral, and then is the ischiofemoral. It's a weak. It can be seen posteriorly. Synovial membrane, obviously it will line the capsule and non-articular surfaces, ligament of head, fat in the acetabular fossa, and it communicates with the psoas bursa and bursa under the obturator externus. So these will be communicated of the synovial membrane. Because of this synovial membrane, this is called a synovial joint. Obviously, it is a common sense that it will line the inner surface of the capsule and non-articular surface of the joint, and also because the ligament of the head, we have seen that it will cover that ligament and communicate with the psoas bursa and bursa under the obturator externus muscle. So there is also a bursa under the gluteus maximus, which is very important. The trochanteric bursa is the posterolateral aspect of the greater trochanteric and the gluteofemoral ligament, and the vastus lateral ischial bursa ischial at the ischial tuberosity. So here we can see there will be the bursa under the gluteus maximus. These bursa are, one bursa is trochanteric, other is the vastus lateralis ischial bursa and at the ischial tuberosity. These bursa, they are very important to be known. You can, I'm not going into very much detail, but you can see when you have a book with you, you can see these bursa, locate these bursa. What I want to tell you, people, is that these bursa are very important to know, because hip joint is one of the very mobile joint that we always sit, stand, walk, run over this joint. So if there is infection of the bursa, any one of the bursa around the hip joint, if there is inflammation of that bursa, that is called as bursitis, that will restrict the movement of the hip joint. So you will feel pain when one of these bursa is involved in the inflammatory part. That is why it is important to know about these bursas which are around the hip joint, under cover of certain muscles and ligaments of the hip joint. So next is the blood supply. Next is the blood supply of the hip joint. Very, very important, the blood supply of the hip joint. So, the one of the blood supply in the childhood is obturator artery, which is from the internal branch of internal iliac artery via ligamentum teres. It supplies the epiphysis. So if obturator artery is blocked or damaged, that will damage the blood supply of the epiphysis. In elderly, main supply is via the retinacular vessels from the trochanteric and cruciate anastomosis around the greater trochanteric and cruciate anastomosis. The blood supply came through the retinacular vessels in elderly people. Medial and lateral circumflex femoral artery. And when we were discussing about the medial compartment, there I have shown you the two anastomosis, trochanteric and the cruciate anastomosis. You can look at that diagram, how the internal iliac artery is having through its branches having anastomosis with the branches of the external iliac and which continue as the femoral artery, branches of the femoral artery, then anastomose with the branches of the internal iliac artery at the greater trochanteric and at the cruciate anastomosis. You can see that diagram, and from these anastomosis, retinacular vessels, they will go to the head of the femur. Superior gluteal supplies the upper part of the acetabulum. Inferior gluteal supplies the inferior and posterior capsule, obviously because they are in the gluteal region. Transverse and ascending branches of the lateral circumference femoral artery, transverse and ascending branches of medial circumflex femoral and cruciate and trochanteric anastomosis. So here we can see, you can open up the diagram in your atlas and you can appreciate here are the vessels which are supplying the head of femur through branches of the medial and lateral circumflex femoral, and from above the superior and inferior gluteal arteries, they will supply the acetabular part of the hip joint. Acetabular part of the hip joint. So superior gluteal artery, inferior gluteal artery, transverse and ascending branches of lateral circumflex, and transverse and ascending branches of medial circumflex, and the cruciate and trochanteric anastomosis that will supply the blood to the hip joint, both the acetabulum and head of femur. Head of femur is supplied by the reticular vessels through the anastomosis, and acetabulum is supplied by superior gluteal artery, inferior gluteal artery, and the head of femur, transverse and ascending branches of medial and lateral circumflex femoral and cruciate anastomosis. So we can very well understand this. And if there is fracture of neck of femur, that because through this the acetabular foramina passing the reticular vessel to the head of femur, and if there is fracture of neck of femur, they can cause the avascular necrosis of the head of femur. Extracapsular arteries enter the trunk at the base of the neck. So these arteries, they send the branches to the head of the femur, lateral and medial. If at the neck there is fracture of the neck of the femur, so that reticular vessels and other vessels which are going to the head of femur, they will be damaged, and ultimately they will cause the avascular necrosis of the head of the femur. This is very common, seen in the elderly peoples who accidentally got their femur fractures, pathological or due to injury fracture. There is the avascular necrosis of the head of femur due to this cause. Nerve supply from any the nerves which are close to the joint will supply it. Femoral nerve, obturator nerve, superior gluteal nerve, nerve to quadratus femoris, and posterior dislocation may damage the sciatic nerve. Pain in the hip referred to the knee. Pain in the hip referred to the knee. Why? Because the nerves are passing from near the hip joint to the up to the knee, so that pain can be referred to the knee by the pressure on the nerve. So there are three nerves: femoral nerve, obturator, superior gluteal nerve, which are mainly supplying the joint. And if there is dislocation of hip joint, so posteriorly is the sciatic nerve present, which can be damaged. Relations, for this purpose you have to open the atlas, see which structures are passing anteriorly, and there you will see rectus femoris, adductors, adductor longus, pectineus, psoas, femoral sheath and femoral nerve, they are all lying anterior to the joint. And inferior and posterior, the obturator externus passes inferior and then posterior to the joint. Superior gluteal artery, inferior gluteal artery, sciatic nerve, posterior cutaneous nerve of thigh, nerve to obturator internus, quadratus, femoris, pudendal nerve, they are all lying posterior to the hip joint. And it is obvious that they are lying in this area, so this area is posterior to the hip joint. Inferior and posterior to the hip joint. Laterally, the greater trochanteric and the muscle which will cover over the laterally, gluteus minimus, medius, superior gluteal vessels, and between it, iliotibial tract is lying lateral, and superior 3/4 of the gluteus maximus of that is lateral to the joint. So these are structure which crosses lateral to the joint. Iliotibial tract is very important to know, and also the gluteus maximus. Medius will also be lateral, and if this is lateral, this will cause the abduction. And posterior relations, piriformis, superior, gemellus inferior, obturator internus, quadratus, adductor magnus part, hamstring part, especially the hamstring part of the adductor magnus, obturator externus, gluteus maximus, these will all, part of the gluteus maximal is posterior part will be lateral to it. So these muscles will be lying posterior to it. Movements then comes, so it is a multi-axial joint, so there will be flexion, extension, and the abduction, adduction, and circumduction. All these movements will be present. So these movements are called the muscles and tendon of the muscles which are passing anteriorly to the hip joint. They will cause, obviously they will cause the flexion. But if you flex, you are sitting on a chair, if you flex your leg, thigh, flex your hip joint, and you see that that is limited by the anterior abdominal wall. You cannot flex fully due to resistance by the anterior abdominal wall. And these muscles which are passing anteriorly are the iliopsoas, then is the from the pubic pectineus muscle and part of the adductor longus and rectus femoris from above the reflected part that will cause the flexion of the hip joint. All these structures which are passing anterior to the joint will cause the flexion. Extension, the muscle part which is lying posteriorly, and the hamstring muscles which are passing semitendinosus, semimembranosus, first 10 degree is by the hamstring muscles, and extended knee. In the extended knee there is more extension, and it is adductor magnus part which is hamstring by that house. But the most important muscle is gluteus maximus. When the hip is flexed 45 degree, so from flexion of 45 degree, then hip joint is extended by the gluteus maximus. And this, if you apply, if you are sitting on a chair with your hip joint flexed and you try to stand, then is the most efficient muscle is the gluteus maximus muscle. Or while you are going upstairs and you put one foot over the next step and then extend the hip joint to go upstairs, that extension is caused by gluteus maximus, because your knee, your hip joint is almost 45 degree flexed when you put your foot on the step On the next step, you flex the hip joint up to 45 degree, and then you extend the hip joint to go upstairs, and that part is played by the gluteus maximus. First 10 degree is the hamstring part only. Otherwise, the most important muscle is the gluteus maximus muscle. Adduction, the muscles which are present on the adductor side, adductor longus, brevis, magnus, and some of these muscles can also flex or extend the hip joint depending upon the position of the muscle. As we have seen that adductor longus will also cause the flexion, and adductor magnus hamstring part will cause the extension of the hip joint also. So the main function is by the adduction, but along with that, due to their position, they can cause some of these muscles, they can cause flexion or extension of the hip joint. Abduction is very important. Abduction is by the gluteus medius, the main muscle. Then is the gluteus minimus, and standing on like gluteus medius and minimus abduction by preventing adduction. They prevent the adduction, and then during the standing, they play a very much important role in the gluteus medius. How it will produce, that you will study while you will study the muscles in the gluteal region, the role of gluteus medius and importance of the gluteus medius muscle. In the Trendelenburg's sign, which is in the abductor of the gluteus maximus, how it maintains our gait, and that you will study there. Rotations means the medial rotator, iliopsoas, adductors, anterior fibers of gluteus medius, they are the medial rotators. Lateral rotators are which will be present mostly posteriorly, obturator internal, piriformis, superior gemellus, inferior gemellus, obturator, quadriceps. They are all the lateral rotator of the. So posteriorly are the lateral rotators, medially, anteriorly the iliopsoas, adductors, and fibers of gluteus maximus, which are anterior. They are the medial rotators. They are important in some functions of the during walking of the when you walk on the hip joint. They play a very important role, although they are not as important as you have seen the rotators in the hip joint. So here we have seen these movements. We have discussed today about the hip joint and ligaments of the hip joint, all the things, and the clinicals you can understand very well about the hip joint, limitation of the movement, damage to the acetabular labrum, damage to the head of the femur, pain in the hip joint, the bursas which are involved in the hip joint, and bursitis can happen. There may be tear of the ligaments, lliofemoral in the hyperextension, and other ligaments, they can tear down. And the most important is the avascular necrosis of the head of the femur that can disrupt the joint, and the structures which are present around the hip joint, if they are damaged, they will cause pain in the hip joint. And I think so the best thing that you can learn from the atlas, try to apply the knowledge by doing the movement of the hip joint and by exercising it on the atlas, then it will be easier for you. And inshallah, we will see. We have seen the blood supply. Again, I will repeat from the very first slide what we have learned about it. So we have learned about the hip joint is that ball and second synovial multiaxial, movement free. Then is the stable joint due to the ligaments and the shape of the joint. And then here is the shape of the joint. covering acetabulum, how it is formed, Y-shaped, and which bones are taking part when it ossifies, starts ossifying. And then is the acetabulum, and then is the articular surface of the femur, then is the capsule of the hip joint, then is the ligaments of the hip joint, and then is the lliofemoral ligament, then is the pubiofemoral, ischiofemoral, synovial membrane, the bursas which are under the gluteus maximus, and two other bursas we have seen under the obturator externus, and psoas bursa which are communicating with the hip joint. And then the blood supply from the obturator in the childhood and endarly reticular vessels, superior gluteal artery, inferior gluteal artery, and the cruciate and trunk enteric anastomosis, fracture if the neck of the femur, avascular necrosis, and the nerves which are supplying the hip joint. Then the anterior relations, inferior and posterior relations, lateral relations, true posterior relations, and movements, flexion, extension, adduction, abduction, medial rotator, lateral rotator of the hip joint. Thanks a lot. Allah Hafiz.